Everyone, it's the top of the hour, so we'll get started. I'm Dia Waguespack in Houston, and I'd like to thank you for joining us for today's GlomCon seminar series talk. Today, our talk is titled The Evaluation of Complement-Mediated Kidney Disease, and it is my pleasure to introduce our speaker, Dr. Abdallah Geara.
So going back, I've been in clinical practice for 12 to 13 years. Can someone confirm that you can see the slide that I'm looking at right now, where there is complement?
Yes, we can see it.
Okay. Yeah, going back like to the medical school, we spend a lot of time learning and memorize the complement system, but really in clinical practice, it came up to this as a summary as this figure where we have a classical pathway, the lectin pathway, and the alternative pathway. And we think about an alternative pathway as an amplifying loop that leads to the terminal or the terminal pathway leading to the C5b C9 C5b9, which is membrane attack complex. So this is actually what we were working with for the longest time. We had one pathway or one intersection, which is a C5 convertase, that was quite important because we had therapy for the last maybe 10 or 15 years. This therapy is eculizumab, as you know, that we treated initially paroxysmal nocturnal hemoglobinuria, but for nephrology, we talked about atypical HUS and some other form of TMA where we just try to target C5 convertase. So this was our knowledge. This is all what we needed to know regarding the complement pathway. So it was mainly a splitting and rearrangement of letters and numbers, but really the bottom line was a C5 convertase interaction or intersection that was important. So I'll go over like a case just to illustrate a little bit like how this has changed over the years. So this is actually a 33-year-old female patient that I saw in my clinic maybe 6 months now or 7 months now. So she had miscarriage when she was 24 years old, and she was out of state when all this happened. So she just moved recently to our area. Her miscarriage occurred at 24 weeks due to preeclampsia. And this is like 5 or 6 years ago. She had persistent proteinuria that was treated with RAS. That's how she presented to me. So when we look at TMA or preeclampsia in the setting of pregnancy, we're thinking about a TMA process because preeclampsia is a TMA process. And with pregnancy and TMA, we have different pathology that can present as TMA in pregnancy. We have preeclampsia, which is the most common, where we have glomerular endothelial injury. And we know the mechanism is due to this increase of the soluble FTL1 and endoglin, and which is mainly an ischemia of the placenta, leading to decrease of VEGF concentration at the level of the endothelial cells and dysfunction of the endothelial cells that present with hypertension, proteinuria, and usually it's self-limited after delivery. But other forms of TMA that occur with pregnancy include TTP, and usually that occurs earlier in the pregnancy. As you can see in this nice depiction here, you see that TTP tend to occur more like the onset during the second trimester, because what we see a decrease of the activity ADAMT-13. So if someone has predisposition where genetically they form less amount of ADAMT-13, pregnancy looks like an ideal situation where this TMA presents. But also we have complement-mediated TMA that can look similar to preeclampsia. So if you see here complement-mediated dysregulation or TMA occur following the delivery or during this peripartum period, and typically it present as a preeclampsia that's prolonged, that does not improve after delivery. So that could be a presentation. So the patient might have this diagnosis of preeclampsia, but it does not improve following delivery. So going back to our patient, so after her delivery, she had persistent proteinuria, and she was treated with RAS blockade for a year. And at month 13, she had a kidney biopsy for this persistent proteinuria, just to rule out this potential possibility that this patient has another process going on, being an autoimmune kidney disease or also a form of complement-mediated kidney disease. She had a stable creatinine of 1.5. Her kidney biopsy showed 25 glomeruli, one with global sclerosis, one with focal endocapillary cellularity and mesangial lysis. And there was mild IFTA. And also there was on the IF, it was negative except for arterial C3 deposit, and electron microscopy did not show any electron dense deposit, but there was clearly endothelial cells that are swollen with subendothelial space that's widening with electron-lucent material. So this is what we call a TMA type biopsy, and it did have some signs of chronic changes. So we felt that was a preeclampsia that was improving. To add to the reason that actually the patient came to me is because what happened recently to her sister. So her sister had a pregnancy that was complicated by preeclampsia. That's in the history of her sister. But recently she was admitted with diarrhea and the diagnosis of HUS. And the kidney biopsy did confirm thrombotic microangiopathy. She was started on dialysis because her atypical HUS was prolonged and the diarrhea did resolve, and they did not find any evidence of Shiga toxins. She was treated eventually as atypical HUS with 3 doses of eculizumab, and she died during that hospitalization, and she required dialysis during that hospitalization. So with this clinical history, she came to me for further counseling. So going back to our patient during her pregnancy and during this event that occurred during her pregnancy and her miscarriage, she did have a full evaluation for her TMA, and the complement was normal. The factor H was normal, but the anti-factor H antibody was elevated. It was not retested afterward, and she had a very long stable course with normal creatinine of 1.3 and UPCR of 0.4. So with all of this information, what was her initial